Welcome to the Eating Disorder Hope online conference regarding anorexia, hope and healing in 2018. This conference is designed to provide an international overview of anorexia nervosa and co-occurring issues. And we are very excited to present our keynote speaker today, Dr. Walter Kaye. He is the founder and executive director of the Eating Disorder Program at UCSD Department of Psychiatry. Dr. Kaye's research is focused on exploring the relationship between brain and behavior using brain images and genetics, and developing and applying new treatments for anorexia and bulimia. He is the principal investigator for an international multi-site collaboration on the genetics of anorexia and bulimia. He has an international reputation in the field of eating disorders and is the author of more than 300 articles and publications. He attended Ohio State Medical School, trained in neurology at the University of Southern California, and trained in psychiatry at the University of California. Dr. Kaye was then a fellow and research physician at the National Institute of Mental Health for 7 years, where he conducted research on appetite regulation, behavior, and treatment for disorders. And with that, I would like to introduce Dr. Walter Kaye.
Well, thank you very much for inviting me to participate. I look forward to doing this.
Yeah, we are very honored to have you. So the start of the interview, I'd like to ask you about your role and activities as director of the Eating Disorder Treatment Research Program at UC San Diego Health. Maybe you could tell us a bit about your role and then how your days are spent.
Okay, thank you. I've been here in San Diego for roughly about 10 years. And when I came here, one of the things I wanted to do was to look at the models of eating disorder treatment and trying and advance the field and come up with improved treatment approaches. So we do several things here. We have a very large clinical program. We have a very large biologic research program, and we also do something I think that's relatively still unique, which is we're trying to marry what we're learning about the brain and behavior with better treatment approaches, and I can get into that and talk about that more. So in terms of treatment, when I started this program, I had been involved in running treatment programs at the National Institute of Mental Health and at Pittsburgh, and actually even in the private sector in Washington. And, you know, those programs have been, you know, frustrating and disappointing in the sense that the relapse rate in eating disorders has been so high. And these are often very expensive long-term kinds of treatments. And at that point, I was very intrigued about the Maudsley or family-based treatment as a new model, which of course, you know, brought families in as allies, with the idea being that these often are very, you know, chronic long-term kind of disorders. If you put somebody in an inpatient unit and they get discharged, does the family know, do they understand the disorder? Excuse me. Do they know how to, you know, manage and interact and get their child to eat and maintain their weight after discharge? And so family-based treatment was really an advance, and that's, so we were part of the consortium with Stanford and other centers to do a multi-center study on family-based treatment compared to another family treatment that had more kind of psychosocial kind of aims, and that was a good way of training our staff and forming alliances with other with Jim Locke and Daniel LaGrange in the field, and bringing the family-based treatment to San Diego. But the other thing we wanted to do is we wanted to see if we could do this in a less expensive way to get families to participate. And traditionally, family-based treatment had been done in outpatient kind of settings, and so we started a day treatment and evening partial program here, and we made family-based treatment kind of the predominant kind of treatment for adolescents and children with these disorders. And now the program has really grown. We have actually separate programs for children, often with RFID, adolescents, and then a separate program for adults. And the overarching kind of goal of these programs is to deliver evidence-based treatment. And if you're going to deliver evidence-based treatment, it's only evidence-based treatment if you actually follow the treatment the way it was designed and proven to be effective. And so part of what we've done is we've set up a system that actually trains therapists and supervises them and continues to train them over time to deliver evidence-based kinds of treatment. And that's a very expensive, laborious, difficult kind of thing to do, but we've been able to do it successfully. And I think that that has really fueled our growth, because I think that families and individuals that come here feel that they're getting really, a consistent treatment by informed therapists.
Absolutely, thank you. My next question for you is your research identifying genes that contribute to the development of anorexia and bulimia nervosa. Can you speak to that a little bit for us?
Sure. I started off in an era where we were just, there was a lot of technology being kind of thrown at genetics, and there was the promise and the hope that we would be able to discover the genes that cause behavioral disorders. And of course, we came at this from a perspective that there were single gene disorders like sickle cell anemia, where you discover the gene, you understand the disorder. Unfortunately, behavioral disorders have been turned out to be a lot more complicated than we thought they were going to be. And now it looks like that, there are many genes that contribute to each of which has relatively small effect that may contribute to behavioral disorders. And it's probably going to take a lot longer time to really kind of understand the genetics of these disorders and find the genes and use those to really kind of develop more effective kinds of treatments. I mean, I think the technology is there. It's just not going to happen instantaneously the way we were hoping.
When you run into disappointing results with studies, what do you and your team do? Do you typically continue to go down that avenue and just change course slightly, or due to funding issues and things like that, do you have to abandon some research and just go to in a different direction?
Well, I think you look at the data and you kind of step back and say, gee, we didn't get the results that we wanted to get. Why is that? What were our assumptions, and what's the reality of the situation? And in this situation, I think one of the things that we're discovering, and we can take lessons from other illnesses like autism or breast cancer, and that is that what we're learning in those systems, in those disorders, is that there are systems that are involved. In autism, it may be systems that are very important for development and synapse formation. In breast cancer, it may be systems that are very important in correcting DNA that becomes disturbed. And that genetics play a role in these disorders, but there are many ways to kind of screw up these systems. And that it may be that everybody with autism or breast cancer may have their own unique illness, their own specific, the system gets impaired, but the actual cause of it may be unique to that person. I mean, there's genes that are complicated. Each individual gene can get disturbed in many, many different kinds of ways. So that, that's the lesson I think that we need to start to look at eating disorders and say, what is the system that's really involved in the brain that causes people to restrict eating or restrict and binge and purge? And, what's the genetic architecture of those systems, and begin to tease it apart that way. So it's not that you throw it out, it's just that as you learn more about the biology of the brain and behavior, you can come at it from a more sophisticated, hopefully successful approach.
Excellent, thank you. So in researching you, Dr. Kaye, we realized that you had won the National Institute of Mental Health Senior Scientist Award. When did that occur, and what was that for?
That was at a time when I was at Pittsburgh. I was at University of Pittsburgh for 20 years, running the clinical program and also doing research. And at that time, I was particularly focusing on research, and there was an opportunity. Opportunities at the National Institute of Health, the grant change over time. They have different grant portfolios or different kind of options, and that was really an option at that point to become to get an award just to support my salary, so I could focus full time on research.
So research is absolutely your passion.
Well, the whole purpose of research is to really, not in itself, but to really apply it to really understanding human behavior and develop better treatments. So I'd say my real passion is really using research to develop better treatment approaches, which is what I feel like we're doing here at San Diego now. And, for example, one of the things that we've learned about people with eating disorders, and I'd say there's some controversy in the field about this, is raising the question of what is the etiology. If many people in this cultured diet, relatively few people develop anorexia nervosa. You would think if anorexia nervosa was purely kind of psychosocial in nature, with the amount of dieting that goes on in this culture, it would be very common, but it's not. It's, there's even evidence that maybe the incident hasn't changed so much over time. And if you talk with people with anorexia and you say to them, what were you like as a child before you ever developed the eating disorder? Not everybody, but what most people will say is, as a child, they tended to be kind of achievement oriented. They wanted to get all A's. They were perfectionistic, often worried about things. Some were kind of obsessive. Some were kind of the other way, kind of impulsive and emotionally kind of labile. But there's certain traits. It's not like everybody has all these traits, but people tend to have one or more of a kind of a menu of kind of traits. And but these traits, these are temperament traits. They're not an illness. People don't tend to have problems, and then they start to get into teenage years and they develop an eating disorder. But the thing that we've been very interested in is that those temperament traits, because those seem to be exaggerated when people are ill, but they persist after recovery. And even after recovery, people that have anorexia tend to be anxious, kind of risk and harm avoidant, sometimes obsessive, continue to be perfectionistic and things like that. But they've learned to most people end up recovering either completely or to a large degree. And, often these traits then turn into kind of advantages. People learn to use these in more successful ways. And so, and they often do very well in life. People with anorexia may have, in some ways, even unfair advantages. We see people come back that have been very ill for a number of years, and they're doing terrific. They're at the top of their field. And so, these traits may predispose people to kind of, be very self-disciplined, pay attention to detail, achievement-oriented, work hard. They're probably an advantage in certain fields, engineering, medicine, research, things like that, where it kind of rewards these kind of traits. So as we're beginning to learn more about these kind of traits, we're trying to use that in terms of our treatment to have people, their families and people with eating disorders kind of recognize these traits and try and work, to develop kind of ways to kind of develop compensatory skills to kind of, manage these traits and use them in beneficial kinds of ways. Does that kind of make sense to you?
Absolutely. That's so hope inspiring. And we see that all the time at Eating Disorder Hope, and both in the articles that people send us and who we interact with. Perfectionism particularly is a really common issue. And rather than trying to take the pendulum and swing it completely in the opposite direction, finding that middle ground of where you could use that gift as a strength and then moderate it where it's hindering you seems to be really crucial for recovery.
Exactly. And, I work, fortunately, San Diego here with a group of very, very skillful therapists. And so as a researcher, I kind of say, this is what we're learning. And that I ask the question, how would you use this in more successful how would you use this in treatment? And how can we develop kind of strategies and therapeutic approaches that, teach people to use these as strengths.
Yes, wonderful. That's really encouraging. So I know this is a pathetically simplistic term, and I bet you probably don't even like it, but I hear it at almost every conference I go to. So I'd really like to hear your take of this statement. Genetics load the gun and environment pulls the trigger for eating disorders.
And that's probably true, and I'd say that's probably a good description of what happens, that people have these temperament traits and then they develop eating disorders. And we don't really, that well understand what actually pulls the trigger. And it could be, certainly psychosocial factors, play a role. Stress, it's not unusual to see somebody develop an eating disorder when somebody dies in their family. There's divorce. Clearly, stress is playing a role. Trauma, but it's actually kind of teasing that out at any one individual person. It becomes more complicated, doesn't it? So,
yes.
Yeah.
I reviewed one of your recent articles published in the Clinical Psychology Science and Practice, January 18 issue, and it was titled, "We Are Only at the Tip of the Iceberg, a commentary on higher levels of care for anorexia nervosa." Can you tell us a bit about the study and your conclusions?
Sure. And this was actually, the first author of this is Eunice Chen, who really has, she get the credit for this. I thought it was a very nice article. And it basically kind of describes, we're not there. We're not there yet. These are disorders where we're kind of slowly beginning to understand the causes of eating disorders and develop better treatment approaches. One of the problems in this field is that actually, and I can say this from kind of a larger kind of perspective, is actually proving that one particular approach is useful. And that's really hard when you're trying to provide treatment for people. It's not like you kind of withhold other kinds of all treatments and just use one thing and see what happens to them in 3 years. Nobody can do that, really. I mean, you have to kind of provide everything that you think is useful, and often there's so many different kind of factors going on that it's really hard to kind of tease apart what may make a difference. Or sometimes maybe some people may spontaneously recover and it doesn't really, maybe treatment doesn't make that much difference. They may have recovered anyway, but you can't withhold treatment from people and put them on a waiting list for 3 years and hope to see what happens. So, there's a lot of problems in the field that we don't really quite know how to solve at this point. And that's a frustration. The other thing that's really kind of a frustration from this and other articles that we published is really trying to get comprehensive outcome assessments on people. And for whatever reason, after people are discharged, it's often hard to get 100% participation. In fact, the fall off rate is often pretty high, so that we don't actually know what happens to everybody after discharge. And that's frustrating because maybe those people are doing poorly, but maybe they're doing great. And so those are kind of some of the struggles that we're having in trying to kind of go to develop more effective kinds of treatment approaches.
Would it be helpful to have Eating Disorder Hope or other online communities provide a touch point for these people to interface with the therapist and nutritionist at periods of time over a 10-year interim, maybe?
Yeah, that would be great. We certainly need new models and innovative kind of thinking here, and because what we've been doing in the past doesn't work so good. And so if there are better ways to set up registries and follow up and feed the information back, that would be terrific. You know, there are other countries, who have, national registries and kind of, country-supported, treatment can do this a lot better than we can do this in this country because of there's so many different systems of insurance payments and treatment centers and things like that, to getting kind of a comprehensive overview of what's happening to people is struggle.
And of course, it would have to be really HIPAA compliant and that sort of thing. But we're making huge advancements in technology with HIPAA. So I think that we'll all have to put our heads together and come up with some ideas.
Absolutely. This is critical to really try and figure out what works.
Yes, sir. The other article that I was reviewing was in the Journal of Eating Disorders in December of 2017. It's titled Outcomes of an Inpatient Refeeding Protocol in Youth with Anorexia Nervosa. Can you tell us a bit about the study and your conclusions there?
Yeah, again, this was, I think, a very nicely written article by Tammy Maginot, who's the head of our treatment program at Rady Children's Hospital, where we're able to treat more medically and psychiatrically severe people who need inpatient care. It's a medical unit. But aside from that, the issue is raising the question of how, caloric needs to gain weight, which is, again, you would think that that's relatively straightforward kind of question, but again, it's hard to answer than you might think in terms of how many calories does somebody need to gain weight and how fast are they going to gain it. And I can tell you from my perspective in the field, let me kind of explain this from a different point of view from other data that we've also generated, which is women, generally need about 30 calories per kilogram per day to maintain their weight, with a range of about 20 to 40. This is women that don't have an eating disorder. So if you weigh 110 pounds, that's 50 kilograms times 30, that's about 1,500 calories a day, with a range of roughly from 1,000 to 2,000 to maintain your weight. And in other studies that we've also done with anorexia, one of the things that we've seen is that people with anorexia at home probably eat well less than this amount of food. They may be eating 10 or 20 calories per kilogram per day, people seem to need a great deal of calories to gain weight with anorexia nervosa. Sometimes when I was running the program at NIMH, we were able to measure this. It wasn't unusual that we get people up to 70 or 100 calories per kilogram a day to gain weight. And that was gaining 2 or 3 pounds a week. And people seem to be very energy inefficient, even though they were eating this large amount of calories. They weren't gaining much weight. And one of the studies that we did actually found that some people actually seem to get hypermetabolic and their temperature went up at night. And it's not unusual if you ask people with anorexia what's happening when they're eating a lot of calories. They'll tell you they wake up sweaty and hot in the middle of the night. and they seem to be burning these calories off as heat rather than putting it on as tissue. Completely don't understand that. So, I still think we don't really understand this very well, but people do need, these large amounts of calories to gain weight. And of course, you're worried about, causing problems with that, hypermetabolic syndrome and things like that. And that has to be something to be cautious about. But it's, it's one of these areas we're still trying to define. And of course, the other thing is that people that are really substantial exercisers, in another study that we did, we found that they are the group of people that particularly need high amounts of calories to gain weight because they're burning the calories off doing exercise. So it's really quite, again, it's like genetics. There isn't one answer that fits everybody. There's a range. People have different caloric needs, different amounts of exercise, probably different amounts of metabolic efficiency. So it's, trying to define actually the right prescription is not as simple as it might look.
Yeah, absolutely. Understood. What do you deem the most important research to explore in the next 5 years for anorexia nervosa?
Well, let me be a little bit controversial. We call this eating disorders, but I'm not sure that most people in the field really believe there's a disturbance of appetite regulation. And, our research here and my own kind of bias is that there are systems in the brain that are very important for appetite regulation, the rewarding aspects of food and the motivating aspects of food, and that those systems have not been, if we're beginning to understand them better, I think there's more and more interest in raising the question about whether there's a primary disturbance of appetite regulation in people with eating disorders. Now that we have the brain imaging technology and other technologies to begin to kind of answer these questions, I think that we can do that. And it may be that people may need to have several, disturbances to develop an eating disorder. It may not just be body image alone. Maybe you have to have a disturbance of body image coupled with a disturbance of, the rewarding and motivating aspects of eating to develop an eating disorder, particularly a severe eating disorder. So it may not be one or the other. It may be multiple systems that are involved. Now, why is this important? The reason it's important, particularly for anorexia, is, we don't really have powerful treatments. There's no medication that's proven to reverse, anorexia. The treatments they have, like family-based treatment, are major advance, but people tend to still have, behavioral symptoms. They just, we kind of work around we could develop strategies to get them to eat and maintain their weight. So, the history of medicine is that it's hard to develop an effective treatment until you understand the underlying mechanisms. And so I really think that the important strategies in the next, 5-10 years here is to beginning to understand mechanisms that really contribute to eating disorders, and so that we can actually understand the underlying molecular biology of that and develop more effective treatment approaches, whether they're psychotherapies or they're medication or any other approach. God knows what's going to be out there in the future too. So.
Wonderful. What studies would you like our international community to support and refer participants to? Are there any we could particularly draw attention to?
We are doing a number of studies here. The studies that we're doing at this point tend to be two groups of people, just depending on the time. We study people who are ill with an eating disorder, and they tend to be people that are in our program or from the San Diego community for practical kind of reasons. We also study people who have recovered from an eating disorder, for both anorexia and bulimia. Sometimes, you know, we do that more than others, but those are other studies that we're interested in, and that's those are studies where we really try and get people nationally, you know, to fly to San Diego to participate in those studies. And it just depends on kind of what we're funded for and what we're doing at the time.
So I'd be happy to have Eating Disorder Hope dedicate some significant space to educating people about those opportunities.
That'd be terrific.
Or they could contact. So after this, let's get in contact with who I need to meet with there so we can help support you with that.
Terrific. We appreciate it.
Why is family involvement so important in the treatment of anorexia nervosa, and what resources are there for families?
That's a great question. You know, I think another area that's kind of overlooked in the field is one of motivation and denial. You know, one of the, you know, somebody that's done this a long time, one of the consistent kind of issues you see is that people with anorexia often don't see themselves as having a problem and aren't motivated, you know, to engage in treatment and eat and gain weight. And that's one of the reasons that we're so interested in looking at things like reward and emotion and the neurobiology of those, because it's not just a question of not being motivated to eat. It's also a question of not being motivated to kind of engage in treatment, especially if your life is, you know, at risk and you weigh, you know, 60 pounds or less. And so, you know, I think that that's really kind of a very kind of critical kind of issue here that we need to focus on, and you know, try and solve those kind of problems. Why aren't people kind of motivated? You know, I'm a psychiatrist. I've been treating various kinds of psychiatric disorders for a long time, and most of the time, you know, people come in, they're anxious, they're depressed, and they feel miserable, and they say, you know, like, I really don't like feeling this way. Help me feel better. And you often don't see that with people with anorexia. They, you know, they don't see themselves as having a problem. They're just not motivated for treatment. But the family is very upset. They don't want their child to die, and you know, you know, they read things and they know that there's a high death rate in this field, and so that, you know, often it's only the family that's really motivated for treatment, and so, you know, getting the family involved and helping them to, you know, incorporate strategies that will get their child into treatment, to stay in treatment and get better is kind of critical. Does that kind of answer your question?
Absolutely. And as a therapist and having recovered from an eating disorder myself, I know how crucial the family is. And it doesn't seem like we have enough resources out there for family.
Yeah, exactly.
What would you suggest people seek outside of, you know, their therapist or treatment team? Are there any resources or books even that you would suggest that are helpful?
Well, you know, Jim Locke and Daniel LaGrange have written a number of books and manuals, which are very good, and you know, certainly people can look at. There's, you know, particularly Feast, but also NIDA, you know, organizations that are dedicated to trying to educate people about eating disorders and you know, better treatment approaches that you have a lot of information. But you know, there aren't enough family-based therapists all over the country. I mean, it's still an area where people are learning how to do it, and you know, not everybody has access to a family-based therapist and somebody that's kind of skilled in working in this kind of area, and that's a problem. It really hasn't been solved.
So that kind of begs the question to me, even internationally, if we could provide education online for therapists in groups with experts to kind of disseminate family-based therapy technique,
Yes.
skill, that would be useful.
Yes. Yeah, this is kind of an interesting kind of therapy because you can learn an awful lot about doing it in a relatively short period of time, but to really become proficient and deal with some of the very kind of complicated kind of questions that come up, and particularly in severe illness, we're finding that therapists need an extended period of training as well as supervision from experts who can help them, solve these kinds of, issues and how to strategize and how to kind of work with families. So, unfortunately, it takes a lot more training than anybody would hope for. So.
Yeah, I can see that, and I know how sensitive families are in the treatment process, and we don't want to do any harm.
Exactly.
So we need to do further exploration. I'm so glad that you're an advocate for the family, though. I think that's really a wonderful contribution. What do you see as the key needs of the international eating disorder treatment community in 2018 and beyond?
Well, I would suppose that internationally the same issues exist in this country, that there's a lot of people who have eating disorders don't seek out treatment. Treatment may not be available to them, or affordable treatment may not be available to them, or sometimes they get treatment that may not be particularly useful for them. I think that we're still in the early stages of understanding these illnesses and developing, treatments that are powerful and effective. And that's unfortunately, I think it's just going to take some time to do that. I mean, I think the trajectory is uphill, but these things don't get accomplished in a few years.
No.
So.
Over in London recently at the Eating Disorders International Conference, I continually heard that in the UK there was an 18-month waiting list typically to get into treatment for eating disorders, which was just so devastating. And they were also expressing, Dr. Kaye, that the NHS and their provision of healthcare is really in turmoil, and so there's a lot of change happening, and maybe some good can come out of that where we find ways to get people into treatment earlier.
Yeah, and I have to say the UK has really been on the cutting edge of developing new treatment approaches. We work pretty closely with Ivan Eisler, who is in some ways the primary architect of family-based treatment. I know he's been working with the system to try and improve it. These are complicated things that take a while.
Amen. My last question for you is, what is your greatest accomplishment as a psychiatrist who has dedicated his life to researching eating disorders and helping people?
I think we finally crossed the frontier of really beginning to understand, what's going on in the brain, at least in kind of a gross level. And, starting to identify systems that are important for things like reward and decision-making and inhibitory control and interceptive awareness that, we think are involved in people with eating disorders, and beginning to translate that into more effective treatment approaches and developing the outcome tools. So I think on one level that's, I think we've gotten farther than I ever thought that we would in my lifetime in terms of understanding how the brain works and developing, more effective treatment approaches. And of course, the other thing is I think the field of eating disorders has grown enormously, and we're now attracting a lot of really very kind of competent clinicians and clinical scientists into the field who will, who are interested in doing this and developing this approach and really making a difference in terms of treatment and outcome for people.
Thank you. We just have a few questions from the audience. If your question is not addressed, we will be sure and share these with Dr. Kaye to respond to you afterward. One is, would you consider the international evolvement of eating disorders largely dependent on the westernization of cultures?
It's always there's always questions that are hard to answer because you don't know how much of it is due to the fact that there's more recognition and treatment availability, and how much of this is psychosocial kind of influences, or more likely it's some kind of complex interaction between them, which is responsible for this. If I'm trying to speak as a scientist, I don't know if there's enough data to know. So
yeah, understood. Another question is about medication treatment with anorexia nervosa, that it's commonly thought that until weight has been restored enough, medication is not helpful. Is that accurate?
There have been some, first of all, I don't think there's enough studies done to really know for sure. There's only been relatively few studies in the field in terms of SSRIs like Prozac, and the data is to some extent conflicting. People, now that we're beginning to think that basal ganglia systems that involve dopamine may be involved in people with eating disorders. There's more interest in looking at medications that have some dopamine effects, like Abilify or aripiprazole is the other name of it. And there's several recent uncontrolled trials that really tend to support this in some people. This is an area where we need well-designed, controlled studies. But I think there's a lot of promise as we begin to understand mechanisms better. This is probably an area of much promise, at least for some people, just as it has been in other areas of psychiatry. I mean, these are not magic bullets. They're not, they don't tend to cure people, but they can often be useful in reducing symptoms. And sometimes, reducing symptoms allow people to use psychotherapies more effectively.
Yes, absolutely.
Yeah.
Absolutely. Dr. Kaye, thank you so much for your time. We really appreciate it.
All right. Well, thank you very much for asking me and involving our program. So,
all right, have a great day.
Bye.
Bye-bye.